Before we begin this model, we would like to briefly introduce what and who TEFI is. The Texas Epidemic Public Health Institute, which is also known as TEFI, is headquartered at UT Health Houston School of Public Health. It is a state organization that works to keep Texans safe and the Texas economy strong by preparing for the next real infection disease outbreak. TEFI continues to work on developing critical programs, producing educational summits based on public health preparedness and certification programs, and currently expanding its programs, training, and more while growing partnerships and offering resources across the state. Under TEFI, there are three different operational cores: the Training and Resources Core, the Readiness Core, and the Communications Core. The Small Rural Healthcare Systems program is under the Readiness Core, and the overarching goals of our program are to provide small rural hospitals with infection prevention education and readiness, and provide rural communities highly impacted by the pandemic with local resources they can use to prevent diseases to avoid small rural hospitals reaching capacity. I am pleased to introduce myself, Oluwatoyin Akanji, as an MPH student here at the UTL School of Public Health. I am also a graduate research assistant for the Small Rural Healthcare Systems program for TEFI. I graduated from Rowan University with dual degrees in biology and health sciences, and I have some years of experience working in infection prevention and control education to the community. The second presenter here today will be Kayla Rush. She graduated from South Dakota State University in 2012 with a bachelor's in biological sciences and graduated from the UTL School of Public Health in 2018 with a master's in public health with a concentration in environmental and occupational health. After graduation, she entered into the field of infection prevention and control in acute care hospitals, where she obtained certifications in public health, certified in healthcare accreditation process, and became certified in infection prevention and control in 2019. During the COVID-19 pandemic, she had the opportunity to work in acute care hospitals in Texas, a long-term health acute hospital and skilled nursing home in New York City, and acute care hospitals in California before returning to UT Health to pursue a PhD in epidemiology with a concentration in infection prevention. Let's begin the infection prevention 103 model. The model slide deck and recording will be posted in TEFI's YouTube channel after the presentation for attendees to access. Our learning objectives today will be to describe environmental cleaning, disinfection, and sterilization practices, to identify safe environment of care practices, and lastly, to describe and explain the elements of construction and renovation practices. The first section we're going to discuss today is the environmental cleaning, disinfection, and sterilization practices. The terms cleaning, disinfection, and sterilization are used interchangeably. This is a common misconception, and it is very important to understand the differences between the three to be able to determine which method is suitable to use. Cleaning is a mechanical removal of visible surface contaminants. This is typically done by using water and soap, also detergent. While cleaning does remove dirt and reduces microbial population, it won't actually kill bacteria and viruses. Disinfection uses chemicals, which are called disinfectants, to kill disease-causing organisms. Some common disinfectants are bleach and alcohol solutions. Sterilization is the next method is sterilization. This method gets rid of all microorganisms, whether good or bad, and this is often achieved by applying heat, chemicals, or irradiation. PDI is a popular product line, also known as Sani wipes or PDI wipes. They're commonly used in the hospitals. The most popular top colors are purple, orange, and black or gray. They use different chemical formulations to disinfect different microorganisms, which also means that they have different contact times. The white top is used for cleaning electronic devices that are seen in many patient care areas and offices. The green top is a newer product that disinfects COVID and Mpoxes, and another similar product line are the Cavi wipes. H. Spalding developed a method for disinfection and sterilization of patient care equipment based on their degrees of use. The three categories he described were critical items, which enter sterile tissue and must be sterile; semi-critical, which contacts mucous membranes and requires high-level disinfection; and lastly, non-critical items, which comes in contact with intact skin and require low-level disinfection. An improved hydrogen peroxide-based technology has been introduced in hospitals for the disinfection of non-critical environmental surfaces. It is also being used for high-level disinfection of semi-critical equipment, such as endoscopes and bronchoscopes. This method has the lowest EPA toxicity category, meaning that it is practically non-toxic and not an irritant to the body. Being less toxic means that it's safer for healthcare workers to use and be exposed to. While endoscopes are a crucial diagnostic and therapeutic tool, contaminated endoscopes have been related to more healthcare-associated diseases than other medical instruments. Recommendations for endoscopic cleaning and disinfection has been published, but audits show that good adherence to these guidelines and reprocessing includes 5 steps after leak testing. The first one is mechanically clean internal and external surfaces of the bronchoscope. The second one is to immerse in high-level disinfectant, then rinse with water, then dry with alcohol and forced air, and then lastly, store by hanging vertically in specific dry hanging cabinets. Studies have shown that healthcare-associated pathogens like MRSA and C. diff often remain on environmental surfaces for days and sometimes even months. The contact time of a disinfectant is the total amount of time that the surface must remain wet for it to be free of all microorganisms. The contact time is always listed on the product label, and it's important to look to read the product label before using the product. This time is typically referred to in minutes, and it can last from a minute to 30 minutes. There are several factors that influence the contact time required for effective disinfection, and the first one is type of disinfectant. Different disinfectants have varying contact times and for requirement. The pathogen susceptibility. Some pathogens may require longer contact time than other pathogens. The last one is surface material. Some surfaces may require longer contact time than other surfaces. This is an example of a disinfectant label. To know the contact time of the product, you have to read the label carefully. One important thing to note is that if a surface dries before the contact time is up, you will need to reapply the product and ensure the proper contact time is met for the disinfectant to be effective. There are new technologies that have been introduced in hospitals for disinfection and sterilization that might reduce risk from surfaces or instruments. Several new technologies are being tested, including self-disinfecting surfaces that are created by coating surfaces with heavy metals or germicides. Several manufacturers have developed room disinfection units that can decontaminate environmental surfaces and objects if first properly cleaned, and these surfaces use one of 2 methods, either UV light or hydrogen peroxide. It is important to note that these methods supplement but do not replace the standard cleaning and disinfection, since surfaces must be physically cleaned before cleaned of dirt before deploying these non-touch technologies. Copper and copper alloys are known to have antimicrobial properties, as it can interrupt the cellular metabolic activity and inhibit growth of microorganisms. Studies have shown that copper-infused surfaces can inhibit bacterial growth on environmental surfaces, as well as decrease the accumulated bioburden over time in occupied patient rooms. For example, Copper-infused furniture helps reducing nosocomial infection in patients, as well as environment cross-contamination. Unlike the no-touch methods, surfaces that contain copper provide continuous environmental disinfection on the surfaces that they cover, and this will contribute to the reduction of risk on environmental pathogens. Also, copper-infused dressing can also lower the risk of infection for patients. It is important to note that these disinfection methods both have pros and cons, and thus each specific system should be studied and its efficacy demonstrated before introducing it to healthcare facilities. Coronaviruses can survive on several commonly used hospital surfaces, including metal and plastic, and these can last for days. This is important when talking about high-touch surfaces that are frequently touched by both patients and healthcare workers, which include bed rails, over-the-bed tables, sinks, and portable medical equipment. Studies demonstrated that coronavirus were easily killed on hard, non-porous, contaminated surfaces, and you can find the current information on the Environmental Protection Agency, EPA, approved cleaning list, which is titled List N, which can be searched based on the product's EPA registration number, active ingredient, or contact time for use in local hospitals or industrial facilities and homes. SARS-CoV-1 can be killed within 30 seconds after the application of an 80% ethanol solution. Hydrogen peroxide and quaternary ammonium-based disinfectants have also shown the same efficacy as surface disinfectants, with contact times ranging from less than 1 minute to 30 minutes after application. Regardless of the cleaning agent used, hospitals should adhere to an environmental cleaning policy that requires the correct use of cleaning products and contact time on a routine basis. This infographic is pulled from the EPA website and covers tips as well as how to use disinfectant safely and effectively. Please refer to the website for more information and refer to your facility's policies and procedures to see what products your facilities use. Now, I'll hand over to Kayla Rush, who will continue with the rest of the model.
Thank you, Toyin, for that wonderful introduction. Like Toyin said, my name is Kayla Rush, and I'm an infection prevention practitioner, and I will start off the second section of this presentation today talking about safe environment of care practices. So what exactly is the environment of care? APIC and other organizations list the environment of care, or which is known as an EOC, as anything that involves construction and renovation, equipment and environmental service needs, utility maintenance and use, emergency management, and more in healthcare settings. Essentially, long and short, it's everything in the healthcare settings, from the people, the equipment, the staff that take care and provide care, to the patients that we serve in a healthcare setting. Why is this important to maintain and be aware of? It's important to make sure that we are providing care both safely as staff and providing best care to our patients and producing no harm by upholding regulations that we will talk about later in the presentation. So now that we've defined what EOC is, who's involved in it? Essentially, everyone in the facility is responsible for upholding and following these regulations and recommendations from accrediting bodies. However, some departments will have more of a primary role than others of establishing and implementing these protocols. These primary individuals are usually the Infection Prevention and Control Department, the Biosafety Department, Environmental Health, Employee Health, department leaders, unit leaders, and executive leaders. It will be a collaborative, multidisciplinary team that will help implement these regulations and ensure all regulations, recommendations, and published safety standards are being upheld and maintained. Now that we've talked about what EOC, or the Environmental Code of Air, is, who's involved, what actually is involved in maintaining these regulations, and what does that look like? Healthcare facilities must adhere to both federal, state, and local regulations, along with published guidelines from big accrediting body and other governmental organizations, such as the Joint Commission, the TDAC, the Center for Medicare and Medicare Services, CMS, Centers for Disease Control and Prevention, CDC, National Institute of Occupational Safety and Health, NIOSH, Occupational Safety Health Administration, OSHA, and others. Each facility will be having the role to establish written policies and procedures for cleaning and other components of safety, and these policies and procedures that they will develop and implement must meet regulatory requirements, published safety standards, and current recommendations. As mentioned before, everyone's involved in maintaining and upholding these regulations, but just like others, there's more primary individuals. Environmental service directors, managers, supervisors, in conjunction with infection preventionists and other healthcare personnel, will play a more significant role in determining and developing these policies and procedures that establish what personal protective equipment is necessary in the facility, write guidelines for its use, and select and purchase these appropriate supplies for use. They will also develop cleaning protocols and practices that will create minimal dust dispersion and help us keep our patients and staff safe. These policies and procedures will divide environmental surfaces into two categories. Will first be our minimal hand cup touch areas, or low touch surfaces, which is usually the floors and the ceilings that we usually aren't touching with our hands, compared to those that we frequently come into contact and touch our hands on, or what are known as high touch surfaces, such as light switches, doorknobs, over the bed tables, call lights, etc. These high touch surfaces may be potential reservoirs for multiple microorganisms, and there can lead to cross contamination and infections in our patients. Therefore, these high touch areas will need to be cleaned more frequently to ensure that we are providing best care from our patients and we are not causing them healthcare acquired infections. The main focus of Environment of Care, as we have mentioned, is to uphold these regulations and recommendations, create policies and procedures to ensure a safe environment for both patients and staff. Team members will audit the process, review and witness procedures to ensure that the regulations are being upheld. So we talk about the regulations, but what exactly are they and how do we audit them specifically? Well, an excellent tool to audit them is the Joint Commission Life Safety and Environmental Care Audit Tool, which is pictured here. It's a very detailed 16-page audit tool, which will go through a few of the regulations today in detail. Like any audit tool, there's not a one-size-fits-all for a facility, and it's also recommended to use this tool with other audit tools to produce a very comprehensive round and a good use of your time when you are doing environmental care rounds. So the first regulation that we're going to talk about is Environmental Care number 020301 standard EP9, which relates to fire risk and response plans. It refers to when and how to sound and report alarms, how to contain smoke and fire, how to use a fire extinguisher, assist and relocate patients, and evacuate areas. When it comes to fire safety, it's everyone's responsibility in the facility. It is also something to remember during construction projects and building modifications are occurring. Essentially, when you're doing projects with barriers put up, where is the nearest exit? Where is the nearest fire extinguisher? How are we going to evacuate this area if something happens? The state fire audits will usually be kept with the facilities or engineering department in your facility. However, it is infection prevention and control's roles to confirm that the records are complete, there has been no issues identified, and to monitor fire safety regulations and report any findings to unit leaders and facilities or the engineering department to address. As I mentioned earlier, the Joint Commission audit tool is great with seeing the regulation, but it doesn't necessarily paint a complete picture. Here's some additional things that come into fire safety to look at when you're doing EOC rounds, such as making sure that their hallways are clear except for crash carts, exits are not blocked, doors are not propped open, there's no door stoppers, and there's 5 feet from the clearance of exits. We are not blocking fire extinguisher, pull stations, electrical panels, and we are aware where our gas valve shutoffs are on the unit. And we're also making sure that our fire doors are clear for 3 feet. Our fire extinguishers are currently inspected and they have a DAG and they're clean and we know how to use them. No equipment or supplies is blocking our sprinklers. They should be 18 inches from the sprinkler heads over ceiling. Oxygen storage tanks are properly labeled and stored according to regulations in a specific area, and no loose paper is on the wall since it is classified as a potential fire hazard. The following regulation we will discuss is Environment of Care number 020507 standards EP1, EP2, and EP3, which fall under the emergency power and systems, how they are maintained and tested. The facilities or engineering department will conduct this part of the audit and perform monthly, quarterly, and annually testing. The infection preventionist role is to review and confirm with the corresponding departments that this process is going well and no issues have occurred. This is also important to be aware of during harsh weather conditions or going into natural disaster, and something to be mindful of. Where exactly is your emergency power system and how it's operated? This is especially important now that we are in hurricane season, of where this is, i.e. is it in the basement and is your facility prone to flooding? So what types of controls do we need to implement to ensure that we have power during a natural disaster? If your facility has a diesel generator, it should be tested monthly in accordance of the healthcare regulations. The next regulation falls under 020501, which is the managing risks associated with utility system. This regulation examines airborne contaminants, ventilation system, air exchanges, filtration efficiencies, temperature, and humidity in the facility. Infection prevention and control will collaborate with engineering and facilities, along with biosafety and department-specific units to ensure our regulations are being followed. And when they are rounding, areas that are designated as positive and negative pressure have a corresponding pressure readout. These are usually your surgical or procedural areas, along with your isolation areas as well. Infection prevention will review temperature and humidity logs in procedural areas or where central supplies is stored, along with sterile supplies to ensure that they're within range. Any out of compliance reports will be notified to leadership for them to address. The next regulation relates to medical equipment inspection, testing, and maintenance. This part specifically looks at high-risk equipment, non-high-risk equipment, conducting performance testing, and maintaining all sterilizers. This is important to ensure that critical devices are being sterilized adequately, as we previously discussed in section 1 of this lecture. Infection prevention control will round on these areas where this type of equipment is located and visually inspect the equipment, review logs, interview staff, and ask them to speak on equipment policies and procedure. Infection prevention will report findings back to the unit manager and leadership. If the equipment is out of compliance, infection prevention will report this to the department, who will then remove the device from service and address on working on sending it to the manufacturer, biosafety, facilities, or engineer to address the defect and get it tested before it's put back into service. The second to last regulations we are going to discuss today is 020505, which relates to utility systems inspections, testings, and maintenance. I want to specifically point on EP5, which is a regulation that directly falls under the Infection Control Department. The department will oversee the utility system components with completion dates and results of activities documented. So what does this mean? This means that this regulation refers to that the Infection Prevention and Control Department will audit areas where high-level disinfection and sterilization occurs. This involves IP reviewing logbooks, confirming controls are being ran and they have passed quality control, or what is known as QC. All documentation is completing, interviewing staff regarding policies and procedures, and witness staff performing high-level disinfection and sterilization cleaning procedures. Again, infection prevention will report all findings back to the unit and department leadership to address. The final regulation we'll discuss is EOC 020201, which falls under hospital management risks related to hazardous material and waste. The hospital will maintain a written hazardous material inventory, which includes waste usage, storage, and how it's generated. The policy will be comprised of who handles, uses, stores, and complies with laws and regulation when it comes to hazardous waste. EP3 involves donning and doffing the appropriate PPE when responding to hazardous material, spills, and exposures, while EP11 includes hospital permits, licensures, manifest, and safety data sheets, or SDSs, required by laws and regulations for hazardous waste. Infection prevention and control will round on these areas, review the logs and policies, and report any findings back to the department and unit leadership. They will collaborate with biosafety, facilities, and engineer about any issues and develop solutions together to address these non-compliances. And as I mentioned before, using additional audit tools along with the THC Life Safety and EOC tool can produce a very comprehensive round. Here's some just additional things to look at when you're doing EOC rounds. Eye wash stations should be checked weekly. There should be logs documented that they are in operation and they are clean. There's no debris on them, no cobwebs, nothing sitting on them. No supplies in a healthcare facility should be placed directly on the floor. It needs to be at least 5 inches from the floor. No outdated supplies anywhere in the facility when we're using supplies within expressuration. As we mentioned in Module 2, preparedness using the FIFO method or the first in, first out method will really help address this and keep a good inventory to make sure that expirations are within limits. Lastly, if you're doing, if you have a blood glucose monitoring point of care device that you're running controls on it and it has been cleaned according to the manufacturer instructions for use, or IFUs. And if you have a patient care area where there's refrigerators, the refrigerators are clean, they're within compliance of temperature, both on the refrigerator and freezer side, the temperature is being logged daily, and any patient food is labeled with the patient's number so that we're giving them the appropriate nutritional meal. If a refrigerator or freezer goes out of range, it should be documented that the device is out of range. All items in that device need to be moved to a working refrigerator and freezer. A new log started with those items and then documented that items were removed from the out of range refrigerator and a correction action plan should be in place. Also, when looking at the kitchen, make sure that it's clean and everything's labeled appropriately. Another thing to look at when kitchen is that we do not have any uncovered food, drinks, crumbs, or any of that can lead to pest infestations and other bugs and maggots going into those areas. So it's very important that everything is covered and clean to reduce the infection risk. Another thing to worry about is not having corrugated boxes on your facility anywhere. And what a corrugated box, it's a cardboard box that has the little packaging slits within the cardboard. This is a great area for bugs to lay their eggs and for you to transmit insects into your facility along with other dust and debris. If you order anything and it is shipped to your facility like we all do, these boxes should be broken down in receiving, items wiped down and then brought up to the unit. The corrugated boxes should not be brought up to the unit. Soiled linen hampers and biohazard trash are not overstuffed. There's nothing underneath sinks. And then for HPI or personal health information, all charts are locked and there's no readily available HPI so that we are maintaining and upholding all HIPAA regulations and recommendations. So the last section that we're going to cover today is construction and renovation practices. Construction in healthcare refers to the construction, renovation, demolition, evacuation, and maintenance activities that involves cutting, drilling, grinding, disruption of any ventilation or plumbing systems that may impact patients, staff, or visitors. So essentially, this process is constant and ongoing in healthcare systems that we're always changing, updating to meet the current standards. Construction is overseen by a multidisciplinary team similar to the environmental care rounds, and they will collaborate between departments on construction projects. Everyone in the facility is responsible for overseeing and making sure that construction is going smoothly. However, just like EOC, some individuals have more of a significant role than others. The primary departments that are usually in construction projects are the engineering, facilities department, environmental services, facility operations, the infection control, and then the unit or department specifically where the construction is occurring. Construction has a specific infection control risk assessment, which is called an ICRA, which has a specific risk matrix in a form that we will be talking about in detail to issue to complete the construction permit. This is needed to assess the impact of construction and renovation work in healthcare facilities on the infection control department and practices, and to ensure that the new construction is designated to meet the needs and anticipate the needs of the patient population. Construction will be in 3 distinct components. We'll talk about the planning, collaboration, and execution of it. In the planning stage, infection prevention will meet with engineering, facilities, the project architect, and biosafety to look over the construction project blueprints, evaluate the HVAC system and plumbing systems that is affected by this project, and walk the construction area to discuss physical barriers, pressure changes and requirements, egress regulations, and unit operations to determine what type of construction permit will be issued. The Infection Prevention and Control, or IPC, will then collaborate on the project, issue the infection permit, and review the area before it's released back into operation. After the team meets and walks and discusses the area, they will sit down to issue the ICRA with engineering or facilities in the collaboration stage. Infection prevention will then walk through the permit process with engineering and facilities and agree on what risk and precautions should be taken during the project. And lastly, in the execution stage, infection prevention will sign and issue the permit for engineering or facilities to follow throughout the project. The permit will be posted outside the site until the project is complete. During this process, engineering and facilities will present the life safety plan of the construction area to infection prevention to sign off to ensure that all areas of the Life Safety Joint Commission regulations are upheld and covered during this project. In addition, infection prevention is responsible for auditing the process and reporting any non-compliances to the team so that the engineering and facilities can address them right away. When the project is complete, infection prevention will review the project and the area and release it back into operations. And we will discuss the 2 different types of ICRAs. There is the classic ICRA 1.0, which you'll see here, and then we have the ARISE ICRA 2.0. The first classic ICRA can be used and modified to the specific project and is shown here. This form has fewer details and classes than the ICRA 2.0 that you'll see on the next slide. Some facilities are still using the classic IPRA 1.0, which is fine. However, industry standards are encouraging facilities to switch over to the 2.0 revised version. Both ICRAs, whichever one you're using, all areas should be checked, dated, and signed by the appropriate individual before being posted. And then here is the second type of ICRA. It looks slightly different than the one that you just saw. There's more components, and we will cover each of these steps and areas in detail in the next slides. So step 1, in a construction project, you will determine what type of construction project activity is occurring. As you see here, there's 4 different types. There's type A, type B, type C, and type D. And we'll kind of give a couple examples of each type. So type A is just an inspection and involves non-invasive activities, i.e. no dust and debris is occurring. We're just inspecting and visualizing in this phase. This usually involves just removing ceiling tiles to look above the ceiling, to assess anything, look at HVAC systems, but there should be no dust and debris in this inspection or visualization step. In type B, it's a small scale, short duration activities that create minimal dust and debris. This can be now working above the ceiling, like if you're pulling cable, or if you need to install a conduit, or other type of mechanical, electrical case areas. Type C is large scale, long duration activities that creates a moderate amount of dust and debris. And this can involve putting up new drywall, doing modifications of a patient room, pulling up flooring, those types of things. And lastly, type D is major demolition and construction activities. These are really big projects that go for months at a time and create lots of dust and debris, essentially putting up new wings, new suites, new buildings, walls. That's your type D. In step 2, you will identify what patient risk group is occurring on the construction project. Again, there are 4 different types. You have your low risk, which is your non-patient care areas. That's your hallways, your offices, restrooms, EVS areas. No patient activities are occurring. Then you have your medium risk, where patient care, supportive care areas, and that means waiting rooms, clinical engineering, materials management, kitchen, cafes, those types of areas fall under the minimum risk. And then you have high risk, which is patient care areas, which are patient care rooms, your inpatient units, your ED, employee health, pharmacy, medication rooms, clean utility rooms, imaging and laboratory. And lastly, you have your highest risk areas, which are your procedural area where invasive procedures and really immune compromised patients are located. So these are your transplant areas and units, your intensive care units, oncology, OR, and all procedural areas in pharmacy. If you compound any type of drugs, that falls under this area, along with areas of sterile processing, transfusions, isolation, and invasive imaging suites. And then in step 3, you'll combine your patient risk group that we just talked about and the project activity to determine your overall class of precautions need to be implemented for this project. And you'll see the matrix here. So there's 5 different classes. There's type A, which is the lower list that you see in green. And then you have the highest risk, which is type 5, which has the most precautions needed, longest project with potentially largest risk to patients. In some facilities, ICRAs are only issued for classes 3 through 5, but depending on your facility, you might be issuing ICRAs for all construction project. As you look into your specific policy and procedures, refer to your facility standards of when to issue an ICRA if you need it through class 1 to class 5. And then in step 4, you will now look at the surrounding area from the project. So step 1 through 3 involves specifically the project, and step 4 looks around it. So that looks at evaluating the units in front, behind, above, below, lateral, diagonal of the construction project. You will want to look at potential noise, vibration, ventilation, and other systems that could be impacted during this project. You want to look for HVAC, your electrical, your plumbing, and kind of see where it goes. If you're not quite sure where these types of plumbing or your air exhaust flow into, it's a really great opportunity when you're filling out your ICRA, since you will be sitting down with engineering and facilities, to ask them for clarification of what is the electrical pathway and what is the HVAC pathway along with the plumbing pathway of this area, and how is that going to be disrupted. They should be able to provide you with an answer, or if you're not sure, you can always go back to the construction project and walk the area to visually see it, and then pull out the facilities blueprints for confirmation of what kind of feeds into each other component. And then in step 5, you will determine what minimum infection control precautions by class are needed to be before and during work activities. So you kind of see here, you have very detailed precautions. Class 1 being lower risk, there's less requirements compared to class 5, where there's many precautions that you need to implement. If you ever have a mixture of classes that you're not sure, it kind of sounds like a class 4 or a class 5, you always want to go up a class and implement more safety precautions at the beginning of the projects to ensure a safe environment for everyone, compared to putting only the minimum precautions in place and then later having an exposure or an issue come up, and then you kind of have to backtrack and then shut the project down, implement more safety standards. You can do both ways, but it's always better to go up a class and put more safety precautions in first at the beginning. And then lastly, in step 6, you will determine what infection control precautions are needed for a completion of the work. And since completing the work is getting lower, that most of the demolition should already be done, only minimal things. There's lower level of classes. You see less requirements from class 1 to class 5. And just like before, if you're not sure which class, if it's a 4 or a 5, always go up a class to ensure that more safety precautions are implemented right away. And then here's just an example of a completed ICRA 2.0 that we talked about in each step, and you can kind of see the layout of it. And then just be mindful that each ICRA will look different at each facility and for each project. This is supposed to be a guideline and modified specifically to the project. So you'll have some variations from ICRA to ICRA, even within project to project. So make sure that you're creating your ICRA to fit the project at hand. And then, as we mentioned before, the completed ICRA should be posted outside of the construction project, and it's recommended that behind it, there should be a paper for taking notes when you're auditing the process. As we mentioned, that is infection prevention's role of responsibility to audit the compliance during the construction project. Here's just some recommended columns that you can include. Just do something with the date of the auditor, auditor's initial. If your project requires positive or negative pressure, you have your readout there if the project is in compliance, and comments. One thing about pressure gauges, there are 2 types. There's a manual and there's the automatic pressure gauge. If the automatic pressure gauge is nice because it's giving constant reading, and it usually uploads to an electronic software so that anyone anywhere can access and go and look at it, which is really great. But they are a little bit more spendy, so some facilities still have manual pressure gauges where you physically have to go in, look at the button and click it to get the pressure reading. If you do have a manual pressure gauge, that's fine. However, you need to be mindful that on weekends, holidays, that someone needs to physically come in and document the pressure reading. Infection prevention is that's under their role and responsibility, but they can delegate it to someone else. But again, just refer to your facility's policy and procedure when it comes to construction practices. And as we just talked about, it's infection prevention's role for construction monitoring. But before you go into a site, you want to make sure that you are safe. This is an active construction site, so you will need the proper PPE. That could be a hard hat, closed-toed shoes, a vest, eye goggles, pants. If you're not sure what to wear, ask the foreman or the facilities or operations director of the project. They should be able to inform you what PPE that you need before going into the construction site. While you're there, look at negative pressure components, evaluate if there's any breaks in the barriers. As you see in one of the picture, always look in the red circles, look at the corners to make sure that the seals are still intact. You can evaluate the level of dust and debris in the facility, look how dirty it is, that there's not debris scattered everywhere, it's safe. The vents and HVAC systems are covered or they're shut off, or you know how they're expelling out of the system and they're not going into another unit, and that confirm that egress regulations are being followed and being maintained. And here's just some quick pictures. The first picture is the ICRA posted in the green circle. The middle picture is a sticky mat going in and outside of the construction zone that will help not transmit debris from an active site into a clean area. It can even be, the sticky mat can be posted on the outside or on the inside of the construction area. And then lastly, the end picture is a digital pressure gauge that is giving the reading, maintaining the negative pressure for the site. And then the final step of the construction process is infection prevention, reviewing the newly constructed area before it's released back into operations. And we want to ensure that the environment is clean, everything is cleared out, all regulations have been completed before we're said it's ready to go. Infection prevention will physically go there, and sometimes it is done in multiple stages. You'll do that close to the end when they're taking down the barriers before you're releasing it back into operations. So it just kind of depends on you and your process and the specific project. Another good thing to do before releasing it or giving it the okay back into operation is that you've confirmed with your collaborative partners such as environmental services, facilities, operations, biosafety, that all steps have been completed, everything's been checked, we have documented, and we're all set to go before you release it back into operations. So I know we've talked a lot today about many, many different things when it comes to very important things in infection prevention. Some of the main things that we talked about today were the cleaning, disinfecting, and sterilization. There are different processes that involve different devices, such as non-critical devices, semi-critical devices, and critical devices that use very different reagents and need to be followed to ensure that we are cleaning, disinfecting, and sterilizing appropriately. We went over some environmental care regulations, specifically on the Joint Commission audit tool, which we defined as the environment of care involves a very multidisciplinary team that is responsible for ensuring regulations and safety standards from accredited agencies such as Joint Commission, CMS, CDC, NIOSH, OSHA, etc., are being maintained so that we're ensuring a safe environment for both patients and staff. And lastly, we talked about the ICRA process and issuing the construction permit, which is called an ICRA, which is a very detailed process with lots of steps with, again, a multidisciplinary team. But it's very important that we gain a 360-degree understanding of the project so we know what safety measures to implement at the beginning to ensure that we are providing a safe environment both for staff and for patients. And then before, we're just going to do a couple quick announcements before we open it up to the question and answer section. Immediately after the lecture, you'll receive a post-survey evaluation, or if you want to click on this QR code, it's a quick survey that just kind of lets us know and get feedback on today's lecture so that we can help build these lectures to better serve you and that you're getting what you're needing out of this. Our next module will be module 4. It'll be presented on September 20th from 2 to 3 p.m. and it is titled Implementation of Infection Prevention and Control Programs. We will discuss topics of the infection prevention control programs, surveillance and epidemiology investigations, management and communication. And we just want to thank you all for logging in today and your attention while we went over today's TEFI Infection Control Series Module 3. And then lastly, come connect with us. We're the Rural Healthcare Corps at TEFI, specifically on infection prevention. Here's all of our social medias. You can reach out to us via email, and here's our number as well. And we just want to say thank you again. And just to say that this presentation was recorded. The recording will be posted on the YouTube channel later, along with the slide deck, so that you guys can access it. And then at the end, there are links to some resources that you guys could use to develop in your own facility. So we just want to say thank you again, and we'll open it up for questions. So if you just want to put your questions in the chat, we'll go over them.
In the meantime, Kayla, while we're waiting for questions, do you want to go back to that slide that had the survey QR code?
We're having a little bit of technical difficulty with the QR code on the last slide. So it's not working, but you will receive an email later with the link to the survey. Yes, in the chat, the slides will be available later on our TEFI website, that you can go in and access that and get all the links to the resources as well. Well, if there's no questions, we just want to say thank you again, and feel free to email us with your questions individually as well. And thank you again for attending today's module.